from the last lecture, we talked about the birth asphyxia and the hypoxic ischemic encephalopathy, and we regard these events as a sort or type of birth injury. And we call it is under the section of the hypoxic injury. And now we will talk about the other part or other type of birth injury, which is the physical birth injuries. We can call it birth trauma. So both the birth asphyxia and the birth trauma can be regarded as birth injuries, one on the hypoxic ischemic type or aspect, and other on the physical aspect. First off, we will know the objective of the lectures, inshallah. We'll start with definition of birth trauma. Actually, we have two definitions for birth trauma. We can say it is structural discomfort or injury that happened to the birth, affecting on the function or the structure of tissue or organ. Now, we will talk about the epidemiology of the birth trauma. Is it common or not? You know, birth canal, of course, is narrow, and it exerting a considerable pressure on the infant. Delicate head, shoulders, and arm. These are normal, and these are largely unavoidable. We can do something with it. But mechanical forces can be enough to inflict the damage to a newborn. But this is not meaning that all traumatic birth injury are always unavoidable. Some of these injuries, some of these physical injuries, I mean, are avoidable when appropriate care is available, and others are part of the delivery process that can be, even when clinicians practice, extreme cautions. So this is mainly the job of obstetrician. The physical trauma that can not be avoidable, this is not their fault, but the avoidable, they should exert the full effort to provide to avoid it. How? We will know how. Now, generally speaking, worldwide and in the United States, the infant birth trauma can be happened in about 2 to 7% of the deliveries. It ranges from just simple like cuts and wounds, facial nerve damage, or it's maybe with intracranial bleeding or severe brain injuries, according to the impact or according to the severity of the physical trauma. Now, you remember that we list the top causes of death, or what we call the leading cause of death in the neonatal period. Now, over the past 20 years, because of the improvement in the medical services, the number of deaths due to birth injuries has declined, and no longer it is listed upon the most common causes of death or the leading cause in the neonatal period. So, this map shows the worldwide. This is what's called the age standardized disability adjusted life year. This is mean the calculating or measuring the life year either lost or disabled by physical trauma, by birth trauma or asphyxia. You can see how it is low in the in Europe and North America because of the progress, because of improvement in the medical service. And here we are in the Middle East, and we are in the range of about 600 to 750 cases per 100,000 inhabitants. So we are still in the middle of the affected regions of the world by the birth injuries. Now, half of birth trauma cases are preventable. How? Two major considerations in many cases could prevent birth trauma entirely. First is the timely recognition of delivery complications. It should be recognized at the proper time. The second is the anticipation of obstetric risk factor. If the obstetric risk factor is anticipated, so the work or the job should be performed previously to prevent or to avoid a large extent of birth trauma. So around 50% of birth trauma could be prevented if only obstetricians had properly evaluated a pregnancy for risk factor beforehand. This means before beginning of the birth process. Now, what are these risk factors anticipated and should be something done to prevent or to avoid them? Firstly, what is related to the mother, like primary gravida. This is risk factor. Short maternal stature. Maternal pelvic anomalies, or what's called the cephalopelvic disproportion. The second that is related to the birth process, to the birth itself, like a prolonged or unusually rapid labor. That's called the precipitous labor, which happens, means the first and second stage of labor, it's not more than 2 hours. Or use of the assisted vaginal delivery, like the mid-forceps or the vacuum extractions. These are risk factors. Something related to the baby, to the fetus himself, like if he is very low birth weight, or extreme prematurity, or the opposite, fetal macrosomia, especially a fetus with large head, or fetal anomalies, or these are risk factors. Something related to the status of the pregnancy. The fetus is normal, but its position, its posture inside the uterus is abnormal or risky, like when there is a severe oligohydramnios, you know, the importance of the amniotic fluid, and or maybe due to fetal malpresentation, like the face presentation or breech presentation, abnormal lie, especially the transverse lie, or versions and extractions. Versions that it's mean the effort that done to recorrect the lie or the presentation of the baby before birth, and the extractions that happened with it or during the cesarean sections. So these are the risk factor. We can avoid half of the birth injury if we especially the obstetrician done something essential to prevent them. Now, what are the types of birth injury? It's better to classify the type of the birth injury according to the site of the injury. So first is soft tissue injuries. Then we will go, this is the most superficial and the most mild one. Then we go deeply to the head and neck injuries. Then we will talk about the nerve injuries, the fractures, and about the intra-abdominal injuries or the visceral injuries. Now we will start with the soft tissue injuries. And firstly, we will start with the mildest one, which is the erythema and abrasion. You can see here, this is the erythema and abrasions, these red lines on the cheek of the baby. This is mainly due to forceps application, and most of them are self-limited and do not require treatment unless the complications occur. The second is, you can notice here that dot spot, the red dot spot on the forehead, on the eyelid, on the upper cheek of the baby, and of course, and I think you may know it, these called the petechiae. And petechiae, it happened due to a tight knuckle cord. That's mean the umbilical cord wrap tightly around the neck of the baby, or due to a precipitous delivery. Precipitous mean the rapidly or the short rapid labor. So there is a change in the pressure between inside outside of the uterus, leading to the rupture of the capillaries. You know, the petechiae is a capillary hemorrhage under the surface of the skin, or because of a breech presentation. This should be distinct from other causes of petechiae that happened due to thrombocytopenia. And we can see the thrombocytopenia in sepsis. So for these petechiae, because of the birth trauma, there is not a specific treatment, and usually it will disappear the first few days of life. Now, this picture, you can see these irregular patches, the red, purple in color, extended around the trunk of this neonate, around his upper limb. And I think you may answer these if you ask about this are ecchymosis and the bruising. Ecchymosis and the bruising, this is again a subcutaneous bleeding. but it's a patchy, and it occurs more with traumatic and breech deliveries, and it's associated with an increased risk of hyperbilirubinemia. We will see it in the next lecture, inshallah, because this is considered a part of concealed hemorrhage. Extravasation of the blood need to be hemolyzed, and the jaundice will increase. This has happened more in a preterm, more than term baby, because of the fragility of the blood vessels. And this may reflect the blood loss. If it is extensive ecchymosis, it may be with extensive blood loss, and it may occur with occult size of internal bleeding. It's sometimes not just the subcutaneous bleeding. It may reflect something inside. But most of the cases of ecchymosis and the bruising resolve spontaneously within 1 week and are mild. Now we will go to other type or other form of the soft tissue injuries, which is the subcutaneous fat. You can find, or you can notice it here, pointed by the black arrows, these areas of redness, of the well-formed redness area on the back of the child. This is called the subcutaneous fat. This can be seen commonly in post-term bones. And this is occurred because of the focal pressure of the skin of the body of the baby against the pelvic bones, and it's happened in the birth process. Subcutaneous fattening process also can happen due to the effect of the birth asphyxia. It is hard and well circumscribed, not like the ecchymosis. And it is surrounded by an area of erythema, but it can be with a flesh color or can be a blue color. It needs a time for resolution, not like the ecchymosis and bruising just within the first week. This may need to 6 to 8 weeks of age. And it requires long-term evaluation, because when the resolution of this subcutaneous fattening process, it may lead to development of hypercalcemia because of the liberation of the calcium from the necrotic tissue to the circulation. Now we will go to the last form of the soft tissue injuries, which is the lacerations. This can be seen due to the scalpel use during vaginal delivery or even during cesarean section. So that's why we say the extraction of the baby may cause injury. The most common site for the laceration, it may be on the scalp because it is the presenting part, or on the gluteal region and the thigh if the patient are breech presentation or they are in cesarean section. So most of the lacerations are mild and just restricted to the skin, but sometimes we may need to suturing it because of the excessive bleeding. And like if you see here, the sutured laceration. Now we will go deeply or more significantly about the birth injuries, birth traumas. We will talk about the head and neck injury. And in head injury, we will classify it again into extracranial injuries, from the superficial to the deep, cranial injuries, and the intracranial injuries. Now we will start with the extracranial injuries. Again, here we have the three important forms and significant forms, and we can see it frequently, especially for the first and the second, which is Caput Succedaneum, Cephalohematoma, and Subgaleal Hemorrhage. So what about the first type, which is Caput Succedaneum? But before I go into the details, I will show you this picture to explain the something about the extracranial bleeding. Here is the cranial bone, and this is the periosteum covering the bone. And here is the scalp, and here is the space between the scalp and the periosteum. So if the problem happened here within this scalp, this is called Caput Succedaneum. If it happened in between, beneath the scalp, but above the periosteum, this is called the Subgaleal Hemorrhage. And if it is subperiosteal bleeding or a collection of blood at the under the periosteum, between it and the bone, this is called the Cephalohematoma. Now, what about the Caput Succedaneum? It's different from in its origin from other part of the extracranial injuries. It is a serosanguinous fluid collection above the periosteum within the scalp. So it is edema. Why does edema happen? It presents as soft tissue swelling with purpura ecchymosis. It may be presented with purpura ecchymosis over the presenting portion of the scalp. You know, the presenting portion of the scalp, it will be against the pelvic or against the birth canal. So there will be a pressure causing the soft tissue swelling, edema. So this is the usual site of the Caput Succedaneum. It may extend across the midline and across the suture line. And this is very important because this is an edema and that happened in the scalp, so it is not limited by the suture line. This is very important to differentiate it from the cephalohematoma. Now, here again, we will show the Caput Succedaneum within the scalp above the periosteum, so it is not limited by the suture line. Here is both bone and this is the suture line. Now, it occurs at birth because it is edema, and the edema disappears within the first few days of life. So it's immediately, and some severe or huge Caput Succedaneum can be seen where there is excessive molding of the skull bone and overriding of the bones, especially the parietal bones, to make the head of the baby is appropriate or fit to pass it through the birth canal. So molding of the head and overriding, it will disappear during the first weeks, maybe later on, but the edema just in a few days of life will be resolved. Sometimes it is not just edema, there is a hemorrhagic caput. This means there is a bleeding within the edema. So sometimes it may be severe, or it may even causing shock or require blood transfusion, and of course it will exaggerate the bilirubin level or the neonatal jaundice, but this is rarely happen. Most of the Caput Succedaneum are just edema resolving with several days of life. Here we can see the Caput Succedaneum, and because it is edema, it is a soft tissue swelling, so it can be pitting, can be pressing, because it is just edema. This is you can see here the pinch of the finger, and you can see here the more bulging of the head because of this is the molding of the skull bone and the Caput Succedaneum at that point of the presenting part of the skull. Now, what is the management should be done for Caput Succedaneum? No specific treatment is needed in most of the cases, but if extensive ecchymosis are present, so hyperbilirubinemia may be developed, and it should be managed accordingly. And rarely, if it causes shock, we say it's important to give the blood to correct the hypovolemia and acute blood loss. Now we will go to the second important form of the extracranial injuries, which is the cephalohematoma. Here is a subperiosteal blood collection. So this is not edema, this is hematoma caused by rupture of vessels beneath the periosteum, but it is limited by the periosteum and limited by the suture lines. It can happen in 1 to 2% of all deliveries, and this is regardless of the mode, cesarean section, vaginal, assisted, or spontaneous. Now, it's important to differentiate between the cephalohematoma and the Caput Succedaneum. You can see here, this hematoma is limited by the suture line because it is subperiosteal, so it cannot cross the midline, not like the Caput Succedaneum. Now, clinical features, of course, it will cause swelling, usually over a parietal bone and maybe on the occipital bone, but the most common is the parietal bone. The swelling, as I said, doesn't cross the suture line, and it's often not associated with discoloration of lying skull. It may be just a small bulging or projection without color changes in the skin. It is limited to surface of one cranial bone, so cannot cross the midline. And the swelling generally is not apparent for several hours a day. You know, this is a blood collection, so it takes time to collect, take time to increase, not like the edema, Caput Succedaneum, which is immediately present after birth. And typically it will be the maximum size reached on the 3rd day of life. Cephalohematoma is all over the course of 4 weeks, more than the Caput Succedaneum, because it's a bleeding, need time to resolve. Now, this patient, you can see here the bulging on one part of his skull, and don't cross the suture line because it is limited to the suture, don't cross the midline, and because this is subperiosteal, you can see here there is no color changes in that point. So this is a cephalohematoma. Now, the management of the cephalohematoma. Firstly, how we diagnose it. It's important to the physical examination. Sometimes we may need skull radiograph, ultrasound, CT scan of the cranium may help us in some vague cases. But usually the physical examination is enough. The treatment, if the infection is suspected without inside the hematoma, so it's better to be aspirated. But most of these resolve spontaneously over 3 to 4 weeks without interference. If the sepsis happens, so you have to administer antibiotics, broad spectrum antibiotics, and if it exaggerates the neonatal jaundice, so you have to manage it with phototherapy. Now we will go to the subgaleal hemorrhage. The subgaleal hemorrhage, it is less frequent than the both previous intracranial hemorrhage, but it is more significant, and we will know how. It's a bleeding between the galea aponeurosis of the scalp and the periosteum. So it is under the scalp, but it is above the periosteum. And here's the point. It cannot be limited by suture line. It can extend all over the skull, under the skull, over the skull. So its incidence, it is 4 in 10,000 in non-instrumented deliveries. So you can see the incidence between it and the cephalohematoma. And the incidence increase in vacuum extraction deliveries. This is regarded a major risk factor to develop a subgaleal hemorrhage. Now, it may cause sequestration of more than 40% of the blood volume because it is unlimited site, unlimited space for bleeding. And the mortality because of this, if it caused sequestration or the shock, it may be 40% in those affected with subgaleal hemorrhage. That's why it is significant. And the death may be from the shock and associated DIC. Now, here, the subgaleal hemorrhage. The subgaleal hemorrhage, you can see here, it is under the scalp, above the periosteum. Huge, because it cannot be limited by the suture line. Now, the vacuum extractor, as we say, it is the major risk factor to develop subgaleal. You can see here, it extends above a large portion of the scalp because it is not limited by the suture line, can cross the midline. Clinical features. It is a firm to fluctuant, maybe firm, maybe fluctuant because it is blood collection. So it crossed the suture line, as we said. The mass is typically noted within 4 hours of birth. Not like the Caput Succedaneum, it is a small, the cephalohematoma, it is a small and mild, take time to even reaching to the maximum over 3 days. Here is just within hours, 4 days. And we may find the classic triad of the significant subgaleal hematoma in form of tachycardia, decreasing of hematocrit, the patient will be pale, and there is increasing in the OFC, in the head circumference, in the first 24 to 48 hours after birth because of the extensive hemorrhage. The lab finding that helping us in diagnosis on the investigations in general is the serial HB and PCV monitoring if there is a dropping. So this means there's ongoing hemolysis, ongoing bleeding. Coagulation profile also, this may be affected. And bilirubin level, because this is extravascular blood loss, lead to hyperbilirubinemia. And sometimes we may need CT scan or MRI to detect the real size of the hematoma. Now, this is a subgaleal hemorrhage. It is a large projection. It is of affected skin because of the application of the vacuum. So the skin looks here as sloughed or injured also. And it is large because it is crossing the suture line. Now the treatment. Most of the cases, again, fortunately, the treatment is just supportive. But transfusion may be required if blood loss is significant. We say it may lead to shock. And in severe cases, just to replace the blood is not enough. So the surgery may be required to evacuate the hematoma and even to cauterize the bleeding vessels. Now we finish the extracranial hemorrhage. And finally, the outcome typically resolves over 2 to 3 weeks. Now we will go deeply inside to the cranial injuries, I mean the skull bones. And here we have 2 types of fractures of the skull bone, linear and depressed. The most common is linear, but it is the mild fall. It usually affects the parietal bone, and it may occur due to compression or from application of forceps. Look at the assisted vaginal delivery, always carry the high risk for developing birth trauma, or from the skull pushing against the maternal symphysis of the ischial spine. So if the skull pushing, this is unavoidable, but forceps, it may be avoidable. Usually need only close follow-up and evaluation and monitoring. It is just a linear fracture, can be seen here by the black arrow within the parietal bone, nothing to do with this. But if we will go to the depressed skull fracture, this is the significant and sometimes. The incidence here is a 3 to 0.4 per 100,000 birth. And of course, the forceps delivery is one of the major risk factors, as we said, and we repeated more than one time. It is associated with increased possibility of intracranial process, especially when the fracture is more than 1 cm. So it is not just that the skull fracture, it may be with intracranial process. We all know how. So close monitoring is enough to manage if. Now we will know the conservative management of depressed skull fracture. If the size of the fracture is less than 1 cm, if it is depressed, and there is no neurologic deficit. The neurologic deficit may be in form of the weakness on one side of the body, or the hemiplegia, or hemiparesis, or there is development of seizure. Absence of these neurologic deficits, it means the conservative treatment is enough in these cases. But no. Here is the picture explain how the depressed fracture appear, and again it mostly affects the parietal bone. Now, this is a huge depressed fracture. You can see the depression of the skull and the parietal bone, and in X-ray it appeared like this. Now, what are the indications of surgical management? We say not all the cases need a conservative, or the conservative is enough. So the surgical indication, if there is a radiographic evidence of bone fragment in the cerebrum, the depressed fracture, bone fragments, portion of it, if it is found within the cerebrum, so we need to evacuate it, need to remove it by surgical interference. Presence of a neurologic deficit, weakness, hemiparesis, hemiplegia, or seizure. Signs of increased intracranial pressure, like the bulging of fontanelle. Signs of cerebrospinal fluid beneath the galea. We can find it beneath this mean penetration or injury to the meninges, or there is a failure to respond to close manipulation. You try to just conservative treatment or close manipulation, but the depressed fracture is not reduced, so the surgical interference here is the role. Now we will go deeply and inside the cranium to the intracranial injuries. And we have more than one type. Epidural, we will start from its relation to the meninges, from the most superficial to the deepest. epidural hemorrhage, then subdural hemorrhage, subarachnoid hemorrhage, then we will go to the intraparenchymal hemorrhage, intracerebral hemorrhage, and intracerebellar hemorrhage. And the deepest one is the germinal matrix hemorrhage, or what we call it the intraventricular hemorrhage. Now, this picture shows the relation of the three types of the epidural. Here is the dura mater. This is epidural, or sometimes called extradural. And here is the subdural hemorrhage, which is the most common cause of the intracranial hemorrhage. And here is the subarachnoid hemorrhage. And here again, you can see the relations of both extracranial hemorrhage to both its relation to the scalp and the periosteum. Now we will start with the more picture showing the intraventricular hemorrhage here and the intracerebral hemorrhage. And you can see here there is a deep intracerebral hemorrhage, and here superficial cerebral hemorrhage just beneath the superficial portion of the cortex. Again, this picture will show the sites and the most common sites to develop. So subarachnoid hemorrhage, it's the blood collected at this portion called the leptomeninges. And here is the epidural or the extradural and the subdural hematoma. Now, what are the risk factors to develop intracranial hemorrhage? Forceps delivery, again on the top of the list. Vacuum extraction. Presence of both vacuum extraction and forceps delivery will increase the risk, of course. Macrosomia, especially large head of the baby. Precipitous delivery, because in abnormally rapid labor, there will be a sudden change in the pressure from inside and outside uterus, lead to rupture of the cerebral blood vessels. Prolonged second stage of labor, again, it may cause or it may carry a risk to develop an intracranial bleeding. We will start with the most common cause of the intracranial hemorrhage related to birth trauma. When they ask you about what is the most common intracranial hemorrhage caused by birth trauma, the answer is subdural hemorrhage. So its incidence, as you see here, is bit up to 3 per 100,000 spontaneous deliveries. And of course, double with vacuum, this incidence, it doubles with vacuum or forceps. And it is 10 times higher if both vacuum and forceps are used simultaneously in the delivery assistance. You can see the risk of forceps and the vacuum. It's caused by rupture of bridging veins of the meninges. It is the most common location is the interhemispheric or tentorial cerebri. The clinical features of the subdural hemorrhage. The patient may be symptomatic in the first 24 to 48 hours. And sometimes, if it's severe, may cause apnea because pressing on the respiratory center, or it may cause focal neurologic deficits, may cause seizure, or may cause lethargy, or even hypotonia. Now, the diagnosis, a cranial CT scan, a cranial ultrasound, a brain ultrasound is sometimes enough to diagnose because the good window provided by the open fontanelle. MRI also is important, and coagulation profile reflects the presence of the bleeding or hematoma. How the subdural hemorrhage managed? Resolved without intervention in most of the cases, fortunately, but surgical evacuation is necessary if it's associated with increase in the cranial pressure, and the form of it is bulging fontanelle on increasing on the OFC or developing seizure. Now you can see this MRI show a huge subdural hematoma pointed by the blue arrow, and here the red arrow is pointing to the a dura mater. So here is under the dura. And this should be managed emergently or urgently by surgical evacuation, because you can see it's a pressure on the cerebral hemisphere causing deviation to the opposite side. Now we will go to the second type of intracranial bleeding, which is the subarachnoid hemorrhage. It is the second most common intracranial hemorrhage in the neonates after the subdural. It's caused by rupture of bridging veins of the subarachnoid space or the small leptomeningeal vessels. And the clinical manifestations, it may be asymptomatic, and the resolution happen because it's just small. It may resolution after several days, and sometimes the symptoms appear at the 24 hours, and like the presentation of the subdural hemorrhage. Now, how we can diagnose it? Of course, the cranial CT, the brain ultrasound, it's important, and LP, lumbar puncture, is important because there is increased number of RBC inside the CSF. This is called the xanthochromia. When the CSF sample, it's bloody at all. The management, close monitoring may be the only needed in most of the cases, but sometimes if it's causing herniation of the CSF, so surgical evacuation is needed. Here you can see this is the site of the subarachnoid hemorrhage shown by the CT scan of a newborn. Now we will go deeply to the intraventricular hemorrhage. And intraventricular hemorrhage, it can be seen in preterm babies and can be seen in preterm babies. But it is more associated with the preterm babies in traumatic deliveries more than the term babies. Intraventricular hemorrhage, it may be happen for other causes than the birth trauma. It may be due to the maturity of the cerebral vasculature, or it may be due to the effect of the birth asphyxia. The risk, of course, will increase with instrumented deliveries. This means the vacuum extraction and the forceps delivery. And the causes, trauma, of course, because we are in the field of the birth trauma. Perinatal asphyxia, if you go back to the last lecture you found, especially preterm baby, it will cause the intraventricular hemorrhage. And it may be secondary to venous hemorrhagic infarction in the thalamus. Hemorrhagic infarction and the bleeding as a response to it. Now, factors involved in the pathogenesis. Ischemia and reperfusion. You remember the reperfusion, and it's a harmful effect on the babies that undergo the birth asphyxia, and fluctuating of cerebral blood flow, increasing, decreasing, and the increase in cerebral venous pressure and the platelet dysfunction because the thrombocytopenia or decrease in its function, not in number, and coagulation disturbance. These are all problems can be seen more in preterm babies, more than the term babies. The clinical features differ from preterm baby to term baby. So in preterm, usually silent or presented with decreased level of consciousness or maybe with abnormal eye movement. But in term, it may be presented with seizure, irritability, apnea, lethargy, like what happened in the subarachnoid and subdural hemorrhage. Now, the intraventricular hemorrhage, whether it happened spontaneously or it happened due to trauma, it can be described in 4 grades, from the mild grade 1, with just in the germinal matrix. Germinal matrix is the area or the tissue that originate the neurons and the glial cells, or to grade 2, that inside the ventricles but not large. Grade 3, it will be accumulation of blood inside the ventricles, and the grade 4, it will extend into the brain tissue around the ventricle. Of course, grade 3 and 4 are significant and usually has a serious bad outcome, while grade 1 and 2 are mild. Here is the CT scan show the intraventricular hemorrhage, and this is a severe intraventricular hemorrhage in a preterm baby. And you can see here different intraventricular hemorrhage in the CT scan. Now, how we diagnose it? Cranial ultrasound. is enough. CT or MRI, why not? Imaging is always superior. And the management, sometimes just supportive care or careful monitoring, or sometimes if it is severe, huge, it may need surgical intervention. Now we finish the head injury, going to the neck injuries. And we have a condition called the congenital muscular torticollis. What happened here? Here is a unilateral shortening of the sternocleidomastoid. So it may occur following a difficult birth. There will be a torsion of that muscle, especially if the baby is delivered after breech presentation. So there will be torsion or tearing of the muscle fiber, as I said, and there will be a hematoma collection and subsequent fibrosis leading to shortening of the sternocleidomastoid. Its incidence is up to 2%, and it's more happened on the right side more than the left side for clear causes. Now, the clinical features. It's usually discovered in the 6 to 8 weeks of life, so not immediately after birth. And the head is tilted toward the side of the lesion and rotated to the contralateral side. I will show the picture for this speaking. The chin will be slightly elevated, and if the mass is present, it's firm, spindle in shape because of presence of hematoma, and it's immobile inside the sternocleidomastoid muscle without discoloration or inflammation, just a swelling. The picture here, so here is the shortened, sternocleidomastoid. So the face, also the head, tilted to that side, and the face to the contralateral, and the chin elevated. This can be seen at 6 to 8 weeks of life. And this baby has a torticollis because of shortening of the sternocleidomastoid on the right side, because we say it is more common on right side. Now, how we diagnose it? Physical examination is important. Radiograph may rule the abnormality of the cervical spines, and ultrasound will show the mass because of hematoma and the fibrosis. The management, gentle stretching. We advise the mother to gently stretch or that side of the lesion. This will relieve the tension, and this will lengthen the sternocleidomastoid. But sometimes the surgery may be needed to correct the short muscles. Now we will go to nerve injuries, and we will talk firstly about the facial nerve palsy. Its incidence is up to 1% of live births. Usually resulting from compression of the peripheral branches. So it is a lower motor neuron, lower peripheral facial branches of facial nerves by forceps. Again, we talk about the forceps. In most of the cases, it resolves in 2 to 3 weeks because it's just a compression. It's a superficial discomfort on the nerve. But the risk factors are the forceps delivery, as we say, and the prolonged the stage of labor. Now, the clinical features. Of course, this is a facial palsy, but because it involves the peripheral branches, so there will be a weakness of upper and lower facial muscles of the affected side. And at rest, the nasolabial fold will be lost, flattened on the affected side, and there will be drooping of the mouth, while the eye will remain always open on the affected side. The baby cannot close his eye. During the crying, it will be more obvious when there is an ability to wrinkling the forehead or close the eye on the ipsilateral, on the affected side, and the mouth will be drawn to the normal side. Laceration and bruising sometimes may be seen because of the forceps use, and there sometimes may be neurologic findings, not just this. So this picture will show, and of course this is a right side facial nerve. You can see here the eye on the affected side cannot be closed, a loss of wrinkles, the nasolabial fold are flat, and the mouth deviated to the contralateral side. And again, this picture shows this baby when crying. It's here can close his eye, but you can see the difference between this side, the normal side, then the affected, and of course the deviation of the mouth to the affected side, to the normal side, sorry. The management. It's important to protect the eye because the baby cannot close his eye, so it may be to lead corneal injury, artificial tear, and put an eye pads is important. And neurosurgical repair may be indicated if there is no resolution of the facial nerve after 1 year of life. Now we will go to what is very important, which is a brachial plexus injury. Its incidence is about 2.5 per 1,000 live birth, and it will involve the paralysis of upper arm muscles extending from the spinal root C5 to T1. The risk factor, again, it will be macrosomia, big baby, shoulder dystocia, traction of the upper arm and or upper limb, and difficult and instrumented deliveries. Again, the forceps delivery may cause it. Breech presentation, the baby extracted while his arm is still in the uterus and may cause a traction of the brachial plexus. Now, just to remind you about the anatomy of the brachial plexus. Finally, we have the 3 nerves, but we have 5 roots. So the problem at the level of the roots. First, we will start with the brachial plexus injury with Erb-duchenne Palsy. It may be Klumpke paralysis or Klumpke palsy, and it may be total arm paralysis when all nerve roots are involved. Now, what about the Erb-duchenne Palsy? It involves the C5, C6. It's most common seen in brachial plexus injury. It's more common than the other. Here, the arm will retain the position of the adduction and internal rotation. Here, there will be loss of abduction and loss of the external rotation. The elbow will be extended, there will be loss of flexion of the elbow, and there will be pronation of the forearm and flexion of wrist and finger. This posture like the waiter tip position. I will show you the slide about this. In the Erb-duchenne Palsy, the motor reflex will be absent because there is a loss of the flexor movement of the biceps. Now, most of them resolve spontaneously and improved in the first 24 hours of life because just a simple or a superficial traction, not a real nerve injury. So the infant with Erb's palsy, of course, will lose the power to abduct the arm, to rotate and the arm externally, as we say, and to supinate the forearm. And it may be associated with a phrenic nerve injury. We see it's C5, C6, but sometimes there will be involvement of 3C5, so because of the common innervation, and here may cause associated nerve and phrenic nerve injury. So here the baby has Erb palsy on the left side. You can see here the abduction, the internal rotation, the extension of the elbow, the pronation of the forearm, and the flexion of the wrist and the hand muscles. So this is like the waiter tip position. Now we will go to Klumpke palsy. It involves the C8 and T1 nerve. So it will result in weakness of intrinsic hand muscles and long flexor of the wrist and fingers. It's not like the Erb palsy on the upper arm. The grasp reflex here is absent. When you give a pen for the baby and try to hold it between fingers, it will be lost. And there will be flaccid extremity with absent reflex. And sometimes may be associated with the ipsilateral Horner syndrome if there is a sympathetic fiber of nerve root T1 involved. Now, this picture shows the baby with a Klumpke paralysis. You can see here the loss of or the atrophy of the intrinsic muscles, but he can flex his arm because the biceps flexor function is preserved. How we diagnose the brachial plexus injury in general, Erb or Klumpke? Physical examination or the radiograph for the shoulder and upper arm. How is the management? Initial treatment is conservative, nothing to do. But the physical therapy should be started and continued weekly to prevent the disuse atrophy and to prevent the contracture of the muscle on the affected side. It may be extended to 3 months. If there is no improvement or recovery after 3 to 6 months of age, it may be considered for the surgical exploration. What about the prognosis? Look, point from 0 to 90, and this is depending upon the extent of the nerve root injury. How is that? We will see. Now, as I said, according to the extent of the nerve injury, this slide shows the nerve root, if it is, or the nerve tract, if it is affected really, or just as a weakness of it. So here is the normal when the myelin sheath, when the axon are normal, and all layers of the nerve are normals. In neuropraxia, here is the effects on the myelin sheath only. And in this is like the axonotmesis, here the axon is affected. And in cases of neurotmesis, here is the nerve, the real nerve is affected postganglionic. And sometimes we have what's called the avulsion of the nerve when the preganglionic is also affected. So according to the site and the severity, the outcome will change. Phrenic nerve injury is important, and it sometimes it arises from the 3rd to 5th cervical nerve root, and it happened in a breech delivery and lateral extension of the neck. The injury lead to a paralysis of ipsilateral diaphragm. So how it is presented? Sometimes associated with brachial plexus. There will be a bulging of the abdomen, disappear, do not happen with the inspiration. And there will be a respiratory distress because this affects the function of the diaphragm, recurrence of episodes of cyanosis, or even apnea. Now, the diagnosis, chest X-ray, show the elevation of the dome of the diaphragm on the affected side, and sometimes there will be mediastinal shifting to the contralateral side. The digital fluoroscopy may show the weakness in the movement of the diaphragm with inspiration. So the management usually supportive, and the close observation is enough if this doesn't cause a severe respiratory distress, but surgical application means putting a pacing for increase or enhance the movement of the diaphragm in some cases. And this X-ray show the elevation of the diaphragm more than 2 intercostal spaces. This is the affected side of the phrenic nerve injury, and this is after the surgical application and putting the pacing for the enhance the movement of the diaphragm, so it return to the normal. Now we will go to the fractures. The fractures, we will talk about the clavicular fracture because this is common and frequently seen during birth. Its incidence 1.5 of birth trauma, and the risk factor, it may be a higher birth weight, big babies, a prolonged second stage of labor also, and shoulder dystocia, and instrumented delivery again, or increased maternal age. The clavicular fracture, this is the shoulder dystocia, and how the clavicular fracture happened during passing through the birth canal. Now, the diagnosis in displaced fracture, we can find the swelling, and by palpation we will find the crepitus by palpation, and sometimes there is a petechiae over the affected side. But if it is not displaced, it takes time to discover after formation of the palpable callus. The management always no specific treatment. It can be healed spontaneously, and we can give a pain relief for those patients. The prognosis is very good, excellent, with long-term sequelae. Now, the long bone fractures, and mostly it affects the humerus or the femur, but it is not uncommon. So the risk factor, breech presentation, the cesarean deliveries, extraction of the baby, low birth weight. The management, it may be immobilization and splinting or close reduction, according if the fracture is displaced or not. Now, this picture shows the fracture of the, this picture shows the fracture of the femur. Now, I reach to the last point of the lecture, which is the intra-abdominal injury. It may affect the liver or spleen. So they are very infrequent, fortunately. And the major causes may be maternal trauma before the delivery, 1 to 2 weeks, or a trauma that happened during delivery. Liver injury more affected than the spleen. Now, clinical features. According to the severity, according to the extent of the injury. So when there is a hepatic rupture or splenic rupture, the patient will be pale, there will be a large hematoma, and there will be abdominal distension and abdominal discoloration. Subcapsular hematoma, in the hepatic, may present insidiously, because take time, subcapsular hematoma, you know it, I know from the surgery, and sometimes may cause anemia, poor feeding, tachypnea, and tachycardia. The adrenal hemorrhage may be caused, but it is very rare, and it happens, so it is presented as a flank mass. Now, the diagnosis, of course, the abdominal ultrasound, CT scan to diagnose the hematoma, and the management either by volume replacement and correction of the anticoagulopathy and hemodynamically stable. The conservative management is only enough, but in hemodynamic instability, a laparotomy is required to control the bleeding. And the patient with adrenal hemorrhage may require hormone replacement therapy because of the effect of the endocrine crisis that have been adrenal crisis. Now we reach to the end of our